Welcome back to Open Med School and Dr. Andrews, Professor of Medicine, Consultant Neurologist. Today I'll be discussing anemia definition and classification based on MCV and reticulocyte count. So let us start. The learning objectives are at the end of the session, you should be able to classify anemia based on MCV and reticulocyte count, define anemia, and apply diagnostic approach. That is the basic idea of today's session. So we'll first define anemia. What's the definition of anemia? Anemia is reduction in the hemoglobin below the normal range for age and sex. So hemoglobin level below the normal range for the age and sex. As per Harrison, anemia reflects reduction in circulating red cell mass sufficient to impair oxygen delivery. As per Wintrobe, it is reduction in hemoglobin, RBC mass, or hematocrit. So basically the definition is same for by most of the textbooks. So what is the practical definition? Practical definition of anemia is reduction in hemoglobin below normal for age and sex, causing reduced oxygen carrying capacity. That is decreased hemoglobin leading on to decreased oxygen carrying capacity. That is the basic definition for anemia. Now we look into the WHO criteria for anemia. So let us see what is the WHO criteria. Very simple to remember. Three numbers 13, 12, and 11. 13 for adult males, 12 for adult females, and 11 for the pregnant. So that is the simple definition for making a diagnosis for anemia. So the key concept to be kept in mind that anemia is something similar to jaundice or fever. It is not a final diagnosis, it is only a clinical manifestation. So when there is a reduced hemoglobin, what happens? It produces reduction in the oxygen delivery to tissues. This leads on to various physiological changes. So what is oxygen delivery depending on? Oxygen delivery depends upon the cardiac output into oxygen content of the blood. Oxygen content can be calculated by multiplying hemoglobin into the SaO2. So this is the basic physiology that you should keep in mind. So now we think about the compensatory mechanisms. When the hemoglobin decreases, what will happen? The body will try to increase the cardiac output. That is why anemia has got a high output feature. Then there will be stimulation of bone marrow by erythropoietin. That is when there is anemia, kidneys will produce EPO, which will stimulate the bone marrow to produce increase in the hemoglobin. So that's the compensatory mechanism. Now go to the classification of anemia. So basically, one is by depending upon the morphology of the RBC classified. Second, based on the pathophysiology. So today I will be discussing mainly the classification based on MCV. So what is MCV? MCV is the mean corpuscular volume. It is calculated by the hematocrit multiplied by hematocrit divided by RBC count in millions into 10. So for example, if the hematocrit is 45, RBC count is 5 million, then the hematocrit will be 9, not hematocrit, the AMC will be 90 plumb liter. So this is how you calculate. The normal, remember 80 to 100 is normal, more than 100 is macrocytic, less than 80 is microcytic. So this is the definition based on the classification based on the MCV. So what is the normal? Normal is 80 to 100 per milliliter. Now the mean corpuscular volume, I already said, less than 80 it is microcytic, 80 to 100 it is normocytic, more than 100 you say it as a macrocytic. So bit briefly going to the microcytic anemia. So when will be the RBCs are smaller compared to the normal, production of hemoglobin or the hemoglobin content is less, production is less. So it leads on to microcytosis. So what are the conditions? You remember the cause of microcytic anemia when the hemoglobin content or production is less. So what are the common causes? Remember, one is iron deficiency, that is number one. Second is thalassemia, anemia of chronic disease, lead poisoning, sideroblastic anemia. This can be remembered by the small tip tails. As for sideroblastic, lead poisoning, the iron deficiency anemia, anemia of chronic disease, and thalassemia. So this is how you remember the causes of microcytic anemia. Now we think about iron deficiency. Iron deficiency anemia is the most common cause of microcytic anemia. So what are the features? You will have low ferritin, high total iron binding capacity. That is a characteristic feature. In thalassemia, what is why in thalassemia there is microcytosis? Because we know the hemoglobin is globin is there. The globin chain synthesis plus heme is hemoglobin. Heme plus globin. So heme synthesis is decreased in iron deficiency. Globin is there is abnormality in thalassemia. That is a thalassemia produces microcytic anemia. You get very low MCV, relatively preserved RBC count. You can say target cells, and the details of thalassemia will be discussed in another session. Then anemia of chronic disease. There is what is happening in anemia of chronic disease. There is inflammation leads on to synthesis of increased hepcidin. That leads on to iron sequestration. So that produces a cell that something like a iron deficiency anemia. Anemia chronic disease normally or usually classically produces normocytic anemia. So classically it's normocytic, but you may get a microcytic anemia because of the increase in hepcidin. Okay, now we think about the sideroblastic anemia. Again, there is a sideroblastic anemia, there is a utilization of iron is improper. There is heme synthesis is defective. You get what is called a ringed sideroblast. So we have discussed about the common causes for the microcytic anemia. In sideroblastic anemia, you get ring sideroblasts in the bone marrow. Causes are alcoholism, drugs, MDs, and you can sometimes get in congenital forms. Congenital cause of sideroblastic anemia. Now you go to the normocytic anemia. Here the RBC the MCV is 80 to 100. That is normal MCV. There are diverse causes. The most important cause, remember, is anemia of chronic disease. So here the major causes, you just remember, major causes are chronic kidney disease. That is the most important condition that you should remember as CKD. Early iron deficiency, bone marrow failure, chronic disease, rheumatoid arthritis, tuberculosis. Increased hemolysis can sometimes produce acute blood loss, can also produce a normocytic anemia. So the common causes, remember, chronic kidney disease and bone marrow failure also produces normocytic anemia. Then chronic disease. What is the reason chronic kidney disease? The kidneys are producing erythropoietin. Chronic kidney disease, erythropoietin synthesis is less, that is leading on. Then I have said bone marrow failure. Classical example is the aplastic anemia. There is a normocytic anemia, there is leukopenia, thrombocytopenia. So pancytopenia is typical of aplastic anemia. Can sometimes pure red cell aplasia can also occur. Then we go to the next major group, macrocytic anemia. Macrocytic anemia classically, the MCV is more than 100. This can be divided into two types. One is the megaloblastic and non-megaloblastic. So that is one classification that you should remember. Remember into megaloblastic and non-megaloblastic depending upon the maturation of the RBC. So megaloblastic anemia, the most important cause you remember is the vitamin B12 and folic acid deficiency. B12 and folate deficiency is the cause for megaloblastic anemia that you'd be coming across frequently. So what are the peripheral smear characteristic findings? Two important findings. One is the macroovelocytes, second is the macropolycytes. So macroovelocytes and hypersegment neutrophils. Hypersegment and neutrophils are called the macropolycytes, more than 5 segments for the nucleus. That is the macropolycytes or hypersegmented neutrophils. Then vitamin B12 deficiency can occur in pernicious anemia. People undergone gastrectomy, ileal disease. So that is why in inflammatory bowel disease. So what are the common causes? You should remember one is the pernicious anemia where there is antibodies against the parietal cells. Second is ileal disease. When somebody has undergone gastrectomy, we can get, and vegetarian diet is the very common thing that you will come across. Then the folate deficiency, the common cause, remember, alcoholism in pregnancy usually get a dimorphic anemia. Dimorphic means two types of morphology. You may get a macrocytic anemia, you can get a microcytic anemia, combination can occur. Dimorphic anemia is characteristic. In malabsorption syndrome, remember methotrexate, folate deficiency and antifolate, so you can get a, so patients on treatment with methotrexate for rheumatoid arthritis or other conditions we can get. Previously, when pseudovidin was there in HIV patients, macrocytic anemia is taken as one evidence that the patient was taking pseudovidin. Then we are classified the macrocytic anemia into megaloblastic and non-megaloblastic. Now we go to the non-megaloblastic. Common cause are liver disease. Get a little macrocytic anemia, alcohol, hypothyroidism. In hemolysis, we can get because reticulocytes are larger than normal RBCs in myelodysplastic syndrome. So this is one important point to remember, can be confused as megaloblastic anemia. Myelodysplastic syndrome where the bone marrow you get a dysplastic cells or bone marrow dysplasia is there. Now you think about that we will be discussing something on the classification of anemia based on the reticulocyte count. So MCV describes the morphology, whereas reticulocyte count describes the marrow response. So this is often useful for physiologically classifying the anemia. So what are reticulocytes? Reticulocytes are young red cells. So reticulocytes are young red cells released from the bone marrow. It contains residual RNA. Normally is 0.5 to 2%. So this is the, so reticulocyte count. What does it indicate? It indicates the bone marrow response, whereas the MCV represents the morphology. So we go into the reticulocyte count. Based on the reticulocyte count, we divide the anemia into those with the low reticulocyte count. That means it's a hypoproliferative anemia. There is a production problem is there. So low reticulocyte count means hypoproliferative anemia, production problem. High reticulocyte count means it's a hyperproliferative anemia. So this occurs in bone blood loss or destruction, hemolysis. So in hemolytic anemia, you get the reticulocyte count is high. So as mentioned, what is the importance of reticulocyte count? Reticulocyte count looks at the bone marrow response. So in hemolysis, it is increased, whereas in conditions where there is a proliferation of precursors are less, you get low reticulocyte count. So low reticulocyte count means the bone marrow is not able to compensate, is failing. So this can occur in iron deficiency, B12 deficiency, folate deficiency, aplastic anemia, and bone marrow infiltration. So remember this, bone marrow is failing to compensate. So all hyperproliferative anemias. In chronic kidney disease, the anemia in chronic disease, kidney disease, there are so many causes. One is decreased erythropoietin. Second is bone marrow suppression because of the uremic toxins. There is some amount of hemolysis. Lifespan of the RBC is less. Then the low platelet, you can get some amount of blood loss. So there are multiple causes, and again think about nutritional. These patients have got lack of appetite and there is a nutritional deficiency. So various types of anemia you can get in CKD. Then high reticulocyte, and I already mentioned, it shows the bone marrow is responding properly. Examples are acute blood loss and hemolytic anemia. Blood loss and hemolytic anemia get a high reticulocyte count. Remember this. Okay. Now you go over little only corrected reticulocyte count. So corrected reticulocyte means severe anemia, reticulocyte count can be misleading. So because of that, you make a correction with the for the hematocrit. So how will you correct it? So corrected reticulocyte count is the reticular retic count of the patient into the patient hematocrit divided by normal hematocrit. Take it as 40 to 45. 45 for male, 40 to 45 for females. This is for correction for the hematocrit. Then there's something called a reticulocyte production index. And the hematocrit is 35 to 45, you divide with 1. 25 to 35 by 1.5. For 15 to 25, divide by 2. And less than 15, we divide by 2.5. So this is the correction factor. So this is the correction for the maturation time. When the reticulocyte production is less than 2, inadequate bone marrow response. More than 3 is an appropriate bone marrow response. So the correction is done at 2 levels. One for the hematocrit. That is the patient's reticulocyte count multiplied by the patient hematocrit divided by normal hematocrit. Then is a correction for the maturation time. That is, this corrected reticulocyte count is divided by a correction factor for the maturation time. Hope this point is clear. So the framework for classification of anemia is based on, one is the morphology, second is by the reticulocyte count. So hope this session was useful to you. Stay tuned for further videos. Thank you.